Hello, I'm Dr Louise Newson. I'm a GP and menopause specialist, and I'm also the founder of the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon. I'm also the founder of the free Balance app. Each week on my podcast, join me and my special guests where we discuss all things perimenopause and menopause. We talk about the latest research, bust myths on menopause symptoms and treatments, and often share moving and always inspirational personal stories. This podcast is brought to you by the Newson Health Group, which has clinics across the UK dedicated to providing individualised perimenopause and menopause care for all women. So today on the podcast, I've got someone called Dr Rebecca Walker with me, who is a GP with a special interest in migraines, as well as hormones as well. And as many of you know, the two are very closely linked. So I wanted to dedicate this podcast to really just talking a lot about migraines. I have a big personal interest being a migraine sufferer myself. And it's really shocking. Menopause is neglected, but migraines are really neglected, actually. They're under-recognised, they're underdiagnosed, they're undertreated. And actually, the impact of migraines is just still not recognised to the extent. So it causes a lot of personal suffering, a lot of professional suffering because people are able to go to work, and a lot of unnecessary costs to the NHS as well because people are not given the right treatments or given inappropriate treatments. So hopefully we can unpick some of what migraines are, how best we can optimise them, because us with migraines know we'll never be cured. It's not curable, but it's manageable. And so we just want some really great tips from an expert. So thanks for coming today, Rebecca.
That's my pleasure, Louise. Thank you for asking me and putting migraine on your agenda, because yes, it's important to me too, for all the reasons that you have said.
Yeah, so it's very timely actually. I'm just coming out of a migraine, so I still don't feel completely with it. But, you know, yesterday morning I had one of these classic times where I was in a important meeting and I suddenly felt all cold and shivery, and I thought, oh, what's going on? And then the day progressed and I knew that I was developing a migraine, and my daughter, who's also a migraine sufferer, had phoned me and she said, Mummy, have you taken aspirin and domperidone? And I was like, no, I'm fine. She goes, no, I can hear by your voice because you're slurring your words. That's something. But it's really weird when you have a migraine, you don't think properly and you can't actually, you know what you should do, but you can't do it sometimes. And then it makes it worse. And then it's sometimes too late because you have this window. And then I was taking amitriptyline, but I knew it wasn't right. But I also knew I had to drive and take my daughter to something else, another daughter. So I couldn't take the amitriptyline. And I hadn't eaten properly. And it's this spiral of it's awful.
I mean, you have just said so many things in that one story.
But it's one of those that I think a lot of people still don't understand. Because when I say to people I have a migraine, oh, do you just have a bad headache? And you feel like ripping their head off, but actually they don't understand. So can we start, Rebecca, with just what is migraine?
So migraine is a complex neurological condition. It is not just a headache. We know that it has a strong basis in genetics. So most of the time there's a family history there. But the genetics are complex, so there is variable inheritance. So some people will express migraine in one way and other family members might express migraine in another way. And I think that's part of the problem too. So it often goes unrecognized from family members to family members. But we know that it's not just a headache. Headache is one symptom of migraine. Headache might not be a symptom of migraine. So there are people out there who will be experiencing migraine where they don't get headache at all. And that's because we know that migraine, so let's go back to sort of basics and some biology. Migraine, an attack of migraine starts with an inherited tendency towards a condition, but we then know that there are environmental, both internal and external environmental factors that push you over your migraine threshold. And once you hit that migraine threshold, you start to get activation in the hypothalamus part of the brain. So this is the thermostat, if you like, the center that controls our temperature regulation, our sleep-wake cycle, our appetite cycle. So when that part of the brain is being activated, we start to get prodromal symptoms, and they might be feeling hungry, feeling thirsty, going to the loo more often, yawning uncontrollably, a dip in mood, slowed thinking processes, neck stiffness. And that might be happening anywhere from a few hours to a few days before you start to get the more readily recognizable symptoms of migraine, which would be the nausea, the light sensitivity, sound sensitivity, the headache. And then, as you are possibly right now in your postdrome, where you're maybe, you're recovering, there's relief that the unpleasant symptoms are passing, but you're still not back up to functioning at your normal 100%, maybe 60 to 70%. Brain still feels thick and foggy. Energy levels are still a bit flat. So that's a typical attack of migraine without aura. There are 3 in 10 people who experience migraine who might have aura as part of their attack. But that just goes to illustrate, firstly, that it can last anywhere from hours to days, but also the myriad of symptoms that a person with migraine can experience during an attack.
And that's really difficult, because I think that's why so many people, it can take a while to be diagnosed. Especially, we see a lot of people in the clinic who have vestibular migraine. So they might have balance problems and they've never had a headache. And they've often been diagnosed as actually having a TIA, a transient ischemic attack. Yeah. And people think that they've had a mini stroke. But when you take the history very clearly, it often isn't, is it?
There's a history of migraine. So vestibular migraine is a really interesting variant of migraine. I see it so commonly presenting in the perimenopause. It's typically characterized by episodes of vertigo that last for maybe several hours or so, accompanied by other symptoms of migraine, so that light sensitivity, movement sensitivity, sound sensitivity, feeling nauseous. Headache doesn't always have to be present. It's usually been there at some point in the past with an attack, but it doesn't always have to be present. And what we often find with vestibular migraine is that headache is there, but it's not the most bothersome symptom. So in migraine medicine, we're really keen on finding out from people what is their most bothersome symptom. It might be headache, but it might not be. It might be balance disturbance. It might be fatigue. It might be brain fog. A whole host of different bothersome symptoms.
Yeah, and how do you define chronic migraine? Because that's a term that's used quite a lot as well. So what does chronic migraine mean?
So I think I'm pleased that you asked about this, because I think part of, again, migraine awareness and helping people recognise that actually they might be experiencing migraine and not just headaches. No one is born with chronic migraine. There is a point at which migraine, which is episodic, so that means it comes and it goes and you feel well in between your attacks, transforms to this chronic, more burdensome, more impactful and potentially life-limiting condition. It comes down to essentially how impacted an individual feels by their migraine, but our classification systems use a cutoff of 15 days. So if you have migraine days that number more than 15 per month, 8 of which really fall into typical migraine type attack days, then that constitutes chronic migraine. So as I said, that's when it becomes really life impactful.
But if you look at disabilities through WHO, it's really up there, isn't it, as being one of the commonest causes of disability, because migraine is so common, yet there's so much we still don't know about it. There's so little research that's done, and there's very few specialist migraine clinics as well, isn't there?
That probably comes back to it being maybe a women's issue. It's predominantly a condition of women, so it affects 3 times more women than it does men. It affects women disproportionately, and men too, but it affects us disproportionately in our midlife. So during most productive years, working age, and that's largely in women due to the impact of hormonal influences. And I think it is stigmatized. It's hugely stigmatized, and it comes down to this lack of understanding. It comes down to thinking of it as just being a headache, something that people should take a paracetamol for and get over and get back into the office for, which means that people are sometimes anxious or nervous about coming forward to volunteer that they have an issue that they need support and attention for. And equally, perhaps as healthcare professionals, we carry our own stigma related to migraine as well, because of a lack of training.
I think you're absolutely right. There is a real lack of training, and it's always difficult in medicine when you're dealing with a condition that there isn't a diagnostic test for. So if I thought you had diabetes, I could do a blood test and I could say yes or no, Rebecca, you've got diabetes or you haven't. With something like migraine, there isn't a test. We sometimes do tests to make sure there isn't a brain tumour or something else causing some symptoms. Not always. Most people don't need a scan, of course. So then you're going with a really good history and story, but you have to be trained to ask the right questions, because if you don't ask the right questions as a healthcare professional, you're not going to get the whole story. And sometimes people don't think something's relevant, because like me at the beginning saying I suddenly felt cold at a meeting, I know that's part of my I know that my headaches and migraines are going to start at some stage, but I try and ignore it. But if I didn't know it was associated, why on earth would I tell a doctor that I feel cold sometimes? You've got to be able to, so patients have to have more knowledge so they can give the good history, but doctors and healthcare professionals need to be asking the right questions, because so often in medicine, when we don't know the answers, it's easy to say, oh, maybe it's because you're stressed. And the number of times that I have been told, but certainly my daughter has, oh, it's maybe because you're a bit anxious. Well, no, you might be stressed because you're in so much pain and disability and you're not being listened to and you don't know how to help, and you're really worried it's going to happen at a time when you are doing something public facing or you're doing something that you can't get out of. Of course, that's going to make you worried, but the worry hasn't caused you to have migraine, if you see what I mean. And that's really hard for patients, isn't it?
It's a real thing, the fear or the apprehension of experiencing migraine is a real thing. And I mean, it is a vicious cycle. We know that the more migraine you experience, the more it does impact on your mental health and your well-being, and the more that makes you more predisposed or vulnerable to experiencing migraine. So it is a vicious cycle, and our stress hormones, adrenaline and cortisol, definitely have a role to play, but they are never the only answer. And I hear it all the time that people, well, I wouldn't be feeling anxious if I wasn't worried about migraine, or I wouldn't be feeling low if I didn't wake up with a headache every day of the month. All of these sorts of things that we hear so commonly in clinics.
Yeah,
so yes.
No, I was just going to say it's very interesting about mood, because there's the anxiety that you can have thinking, oh gosh, I'm going to have a migraine at a bad situation. What am I going to do? But the other thing is, and it's taken me 53 years to realise that actually sometimes when people have migraine or just before it comes, you can get very low in your mood. So I often have feelings of really low self-worth, really low self-value. I really think that I'm no good as a person, I'm no good as a doctor, and it's a downward spiral. And it's only been the last year that I realised that quite soon after I have these feelings, then the migraine occurs. And I've also learnt through my daughter, because she has this as well. And it's like, where's this come from? Why are you suddenly so negative? And then I realised I sit on the phone, I can hear this slurred speech, and so now we can reassure each other. And I think that's really important, because I wonder how many people make the wrong decisions because they're having migraines, if you see what I mean.
Or because they feel that they can't acknowledge that they have an attack, that they need to take a step back. Do you mean that they need to take some time out to recover, give themselves space? But I think again, it comes down to validation, almost being given permission. I mean, it's not your fault that you have migraine. It is the genetic lottery that we are, given. It's no one's fault that they experience migraine. And I think that's also really important, that, it's not something you've called.
No, and that is so important, and for others to understand. So recently for my daughter, I actually helped her write a definition of what migraine is and things that other people can do for her when she has a migraine, because some people, she's only young, and a lot of people do think, oh, it's just a headache, just a bit of stress or whatever. And then because her coordination goes, because her speech goes, because her mind doesn't work, it's very hard then to get the right help. But I've sort of wrote this list about things that are worth thinking about for her friends who are with her. So if she starts to yawn, feel cold, is very hungry, then offer her and make sure she has some aspirin, domperidone, so this treatment that could abort an attack. And also, tell her that it's likely that she's going to have a migraine. Sometimes my husband can see it in my eyes before anything else. He can
You know what?
see.
I think you're absolutely right. I'm so pleased you shared that, because I think you're right. I think as maybe as people experience migraine too, there is this element of denial that happens, and you do need
Yes.
somebody who's objective, who can say,
Yes.
hang on a minute, look, I can see the changes,
Yeah.
I can see you're pale, I can hear it in your voice, this is what we do. And
Yes.
I must admit, again, I'm going to take that away for my adult patients too, that I have for children, so young people who are at school, I have a migraine action plan that they can share with their school, that they can share with their educational environment. That means that this is what I need to take when I have my attack of migraine. This is what helps me. This is what helps me get through my migraine attack. And actually, that's important for everyone who experiences migraine.
It is really important. My daughter always has medication with her, but so often she'll phone me and I'll say, right, have you taken? And she'll go, and then she's clumsy, so she can't open the purse, and then she can't see the tablets, and then oh no, I've run out. So even just the other day, she got a tiny purse and it's just got one of everything she needs in. And then she knows that she's got enough for one attack. And it sounds really simplistic. And we were both saying, when your mind's on it, you think that's so obvious. But when you can't think, it's too much to open a drawer, to look through other tablets. And it's really hard to describe to people. But again, to make it easier, because there are treatments that often, they don't always work, that can reduce, even can stop sometimes a migraine attack occurring, but they can reduce the severity as well, can't they?
They can. So when I'm thinking about looking after people with migraine, the first port of call is always migraine-friendly living. So that's good routines. Migraine is inherently sensitive to change. So keeping good sleep hours, hydration, regular healthy meals is important. But a lot of people who've been living with migraine get to the point where they say to me, if anyone else tells me to drink more fluids, I'm going to, solve them one, because don't they think that I've thought of that already? Then when you move on from living your migraine-friendly life, it's important to have a rescue treatment to hand so that you can abort that attack as soon as possible. And sometimes it can take trial and error to find the right combination of treatments. But actually, what you say, a combination of treatments, it might be an anti-inflammatory, it might be paracetamol if you can't take anti-inflammatories, with a triptan. It's shocking how many people with migraine haven't been offered or haven't sought advice on migraine-specific treatment. Maybe 1 in 4 people with migraine have been offered a triptan. So this is a migraine-specific medication to abort an attack. Having a combination of those, sometimes taking these medicines with a small can of Coca-Cola can be helpful. I have a can of Coke in the fridge with my name on it that no one touches, just in case, for those times.
And that's because of the caffeine, is that, and the sugar?
The caffeine and the sugar boosts. Yeah, absolutely. I mean, I think from, as you will, from your description, I think going through migraine, these genes that essentially mean that you perhaps are more vigilant or more sensitive to the world around you. Being in that condition demands a lot of energy. And so when you're entering a migraine attack, actually that's what your brain is craving. It's craving restoration of good energy levels. And so the caffeine and the sugar boost with the migraine rescue treatment can be helpful. Obviously, we need to be mindful that it's not too much. Too much Coca-Cola is a bad thing, but it can be helpful now and again.
Yes, and you can get painkillers that contain caffeine as well, can't you, that sometimes people find, and taking an anti-sickness can sometimes help too, can't it, with the medication?
Absolutely. The stomach goes into a state of paralysis in migraine. So taking medicine into your stomach, sometimes it just sits there. And actually, a lot of people feel that and describe that. They feel like my system just stops. Some people who do vomit feel like actually the action of vomiting in some ways goes to relieve or bring respite from their migraine attack. But taking an anti-sickness tablet that also works to move medicine into the intestine can also be very helpful too. It's all about getting that medication into the system as quickly as you can. We use an analogy at the National Migraine Centre, likening an attack to a fire starting in the waste paper bin of in your office room. You don't want to go at it with a plant spritzer. You want to go at it with a great big bucket of water, put it out quickly so that it doesn't take hold and burn everything down.
Yeah, it's a really good analogy, isn't it? And there's also some of the triptans you can have as a nasal spray, or they can melt in the mouth, which again is really good if people find that they're feeling sick or they're not absorbing properly. And there are different triptans as well. So what suits one isn't going to suit someone else. Sometimes people have side effects with one and not with others. And it's like anything in medicine, isn't it, Rebecca? You just try something else. So it's really important if people are suffering not to feel bad, to know that you can go back and ask for an alternative treatment.
Say this doesn't agree with me. This isn't the right thing for me. I was listening to a professor of neurology talking about how we define triptan intolerance, and he said, well, perhaps we shouldn't be defining it. Our patients should be defining it for us. That's how it should be. People coming back to us saying, this isn't working for me. Is there anything else I can try?
Yeah, and I think knowing that we're all individuals, because, how I manage or try and reduce my migraine frequency, I have a very routine-y life because I know my brain likes homeostasis. So if I skip a meal, I'm guaranteed to have a migraine.
Yeah.
If I eat processed foods, I'm guaranteed to have a migraine. So if I had a can of Coke and a Mars bar, I know I'd get a migraine. So I don't have it, and I don't have caffeine. But I don't have caffeine at all. I don't have alcohol. I'm really regimented the way I exercise. If I do more than 20 minutes of yoga in a morning before I've had breakfast, I'll get a migraine. 20 minutes is enough, but that's fine. 20 minutes most mornings is good enough for me. But if I go for a long cycle ride, I'll get a migraine. It's really restrictive to the way that I live, but it's actually quite good because it means I have to be healthier because I otherwise would eat probably far worse. I probably would drink alcohol. I probably would go to bed far too late and try and have a lie-in at the weekends. But I can't, because the last thing I want is migraines because they affect me so badly. Some people makes no difference. So if it doesn't make a difference, what you don't want to do is restrict your lifestyle. But I do know also, and I hopefully you'll agree, that any changes in lifestyle, you have to wait a good sort of 3 to 6 months to see if it's made a difference. So giving up drinking for one day and then getting a migraine 2 days later doesn't mean that alcohol is something that you can continue drinking. So you've got to try changing things and waiting.
Yeah, absolutely. I think you're totally right. And it's the same with medical interventions too. So it's the treatments that we use. It seems to take that amount of time for the brain to recalibrate and to adjust to a new way of being, as it were. So yes, give any intervention long enough, and that usually is about 3 months. I agree with you. It can feel very restrictive, but I think, as you've experienced, for most people the benefits outweigh the restrictions or the restrictions that are imposed on life. And often people find that once you've got good migraine control, it affords you a little bit more flexibility. So you can push the boat a little bit. You can go out and enjoy that concert or that meal out. It just might mean that you pay a bit of catch up the next day. Or I think another thing about migraine is, I don't know how you feel about the word trigger, but the more I do migraine medicine, the more I'm becoming less keen on using the word trigger. I think trigger sort of invokes avoidance behavior. And actually what we find with migraine is that people retreat from their lives and stop living the lives that they want to lead because they're avoiding triggers. And I think it's perhaps kinder to ourselves to think of these things as conditions that make us more vulnerable to migraine, and we can prepare for conditions. It sort of creates a more proactive approach. We have some autonomy over migraine rather than it dictating how we live our lives.
I think that's really important. Yeah. And you do have to be prepared, and you do have to, I think you're right, think about alternatives. So even some of the tube lines my daughter can't go on because the noise of the tube, some of them are really noisy and trigger, whereas some of the other, like the Elizabeth line, she said is beautiful because it's really quiet. But she's got and it's really interesting. But once you're aware of it, you think, right, okay, so she plans her journey differently, and and looking at what noise protection you can wear, but you've got to be one step ahead all the time. I look at my husband, and he's been operating
ahead.
Yeah,
it's totally, and you recognised it to start with, and I think again that's why. Well, it's so lovely to be here to say, please, if you're having recurrent headaches, and headache is a symptom, it's not a diagnosis. Do seek advice. It's really important.
I totally agree. And I think that's where using other people to recognise, what did you do differently? Was there anything that sort of brought it on? But sometimes it can just happen. And so, like you say, these triggers, sometimes you do feel like, oh, I shouldn't have gone to that concert, or I shouldn't have done whatever, but actually it could have happened anyway. And so we really need to be careful that we're not just blaming everything that we do on, because they will happen regardless, and sometimes we don't know why.
I think you're right, and different things at different times. So often people come in to see me and they're really frustrated that they haven't found that one single trigger that flicks their migraine switch, and that's because migraine is complex and it's rarely one thing. It's usually a combination of things, and that combination of things might be hormones and a missed meal one month, and it might be a late night and a work deadline the next month. It's just really one of those kind of conditions.
And there are, well, obviously you can't come onto a podcast about menopause and not talk about hormones. So we said at the beginning, it's more common in women. And there are people who, we know it can be triggered by changing hormones. There are some people that have migraines just before their periods, which is when their hormone levels are lower. But especially in the perimenopause, when hormone levels really fluctuate, that can be quite a difficult time for some people who suffer with migraines, because again, the brain is exposed to changing levels of hormones, isn't it?
So I think the perimenopause is the combination of perimenopause, migraine, and midlife is just a recipe for, turmoil for some women. I mean, it's a really, really awfully challenging time due to the reasons that many of your listeners will be familiar with already. So we have menstrual migraine, which is essentially, our thinking is that it's driven to a large extent, and it's complex. This is unlikely to be the only thing, but to a large extent by the drop in estrogen levels coming up to the period after a period of relatively sustained levels of estrogen. So it's the brain, again, adjusting to a changing environment, predisposes to migraine. But then we see these biological changes happening to the cycle, to the menstrual cycle. Cycles in the early perimenopause start to get shorter. So you have these long-lasting attacks. Menstrual attacks of migraine tend to be these longer-lasting, more intense, more disabling, more painful, more nausea, less treatment-responsive attacks. And because the cycle length is changing, they're coming thick and fast, and the recovery in between attacks is getting, the recovery phase in between attacks is getting less, and that drives medication use up. So lots and lots of things are happening to lead to migraine becoming a really big issue during the perimenopause, on top of which you have all the other symptoms of menopause to deal with, potentially low mood, sleeplessness, hot flushes, anxiety.
Which can then make migraines worse as well, of course, can't they?
Worse and worse and worse. So it is important that, yes, that we're helping women spot these things so that we can put together a really comprehensive, holistic, individualised care plan that supports them with all of these symptoms.
Yeah, and most days I have somebody who messages me through my social media to say, I have migraine, I've been told I cannot have HRT, what can I do? So we can still have HRT when we have migraines, can't we? Or sometimes have HRT.
Yes, we can. That's a big myth buster. So yes, of course, women with migraine and women with migraine with aura can also have hormone replacement therapy. I think making the distinction about whether women have migraine with or without aura is important. Women with migraine with aura have an elevated background risk of stroke. It's still very small, but it's higher than women who don't experience migraine or who don't experience migraine with aura. For those women, then estrogen is still okay to give. It should be given through the skin, because that means that it doesn't lead to the risk of stroke or blood clots. Women without migraine with aura potentially have more options in terms of their hormone therapy or the regimens of hormone therapy they could use. But again, that's going to be something that's decided on an individual basis with the clinician who's looking after you, looking at your wider lifestyle factors, so body mass index, smoking, all of that stuff.
Yeah, and it's really important with hormones because, as I've said many times before, there's the three main hormones that we consider: estrogen, which is in estradiol, the body identical estrogen that's anti-inflammatory, progesterone and testosterone. And actually, we work really hard often to individualize dosage and types, because some people, even if they're on a cyclical regime, so they're having periods, they have 2 weeks of progesterone and 2 weeks without, that can sometimes trigger their migraine. So then we give progesterone all the time, because again, it's about the brain having the same, and that can be a lot better. Or sometimes we change oral progesterone to vaginal if it gets absorbed differently and they feel better. And testosterone, again, some people find when they're on testosterone, they have less migraines as well. And there's some small data to show that probably has an effect. But certainly clinically, we see that it does for some women. Some women, if they're not on the right dose of estrogen, it's too high or too low, depending on whereabouts they are. That can even, so some people say, well, I can't take HRT because I felt so awful when I was on it. And then you see what they were on, and maybe it was a synthetic progesterone, or maybe it was a really low dose of estrogen and they needed slightly more or different progesterone. So again, and in the perimenopause, we often have to change it as well because their own hormones are changing, aren't they?
So I think when we're thinking about hormones and the perimenopause, there will be plenty of women out there who have migraine, but it isn't hugely impactful, and they may fare perfectly well with standard regimens of hormone replacement therapy. Making a diagnosis of menstrually related migraine, so having really good diary evidence that shows that there is a real link between periods and attacks of migraine, can be a really helpful tool in terms of working out who's going to benefit from what type of hormone replacement therapy. So women with that type of menstrual migraine sometimes benefit from measures that essentially switch off background ovulation. So you get rid of all those crazy hormonal fluctuations. You have nice, constant levels of hormones. That can be really helpful. Looking at diaries, again, if you've got a woman with really disabling chronic migraine, she may well be having attacks of migraine around her periods too. But actually, when migraine is that burdensome, sometimes hormones aren't the answer, and we really do need to be thinking about adding in additional migraine care. And I think that, again, it's about managing expectations and knowing when we need to step things up.
Totally. And like we said, it's often a combination of treatments. There's not going to be usually one single treatment, whether it's a hormone or non-hormonal, that's going to do it for you. And you might just think, great, I've got the right balance, and then something happens. And sometimes people find that having a good quality magnesium supplement can help. Other people find it makes no difference. Some people find there are other treatments that are available, some on the NHS and some not, or in certain areas or by certain specialists, that can help reduce frequency of migraines. So it's really important that everything is explored if someone's struggling.
Yeah. And that people feel that they can come back, and that I think diaries can feel like just an additional admin task, but actually they're really helpful. They are a really key tool for helping guide treatment response, but also working out what the right treatment is worthwhile to give a go. So I would strongly recommend diaries too. I said to a patient recently that I think living with migraine, and perhaps this is the same with living with menopause as well, or managing migraine in the perimenopause, it's like raising a baby or raising a toddler. Once you think you've got it cracked, they change, or there is change, and it's because this is a constantly changing environment.
Absolutely. And there's still so much that we don't know. We certainly need to do more research and have more evidence, and really look so that it is a condition that is managed more appropriately with less suffering. So there's lots more. I think I'm going to have to invite you back for another podcast, Rebecca, because we've still so much more that we can talk about other treatments, but we will share some resources with the podcast notes. So I'm very grateful for your time. But before we finish, I always ask for 3 take-home tips. So 3 things that you think people could do if they are migraine sufferers and just want to be more empowered about treatment choices. What are the 3 things that they could do?
So I think recognition is the first thing. So recognizing, I'm going to take it back just a step and saying, because I think there are so many women out there who are living with headaches, who haven't had a diagnosis of migraine, and who actually could do with recognizing they have migraines. So that would be the first thing. Get a diagnosis. Headache is a symptom. It's not a diagnosis. What's driving those headaches? I think Keeping a diary is key, because I think, again, that shows us what's going on. Recognising that headache is a symptom that warrants or is worthwhile the time and attention of your healthcare professional, and then getting advice from reliable resources. So my top resources, obviously I'm going to say the National Migraine Centre is a good resource. Katy Munro's book, Managing Your Migraine, is fantastic. These are all great resources for empowering yourself to know more about your condition and what treatment options are available.
Great advice. So thank you so much for your time and sharing so much of your fantastic knowledge. So thank you.
I really appreciate it. Thank you, Louise.
You can find out more about Newson Health Group by visiting www.newsonhealth.co.uk. And you can download the free Balance app on the App Store or Google Play.